the father following the son. So over to Dr. Ramamurthy. As you all know, he's past chairman, scientific committee, past president, AIOS, and chairman of the very successful I Foundation group. Ram is going to talk about management of deficient capsule.
Thank you so much, Dr. Mahipal, for this wonderful opportunity to be a part of your great course once again. And I think the immediate goals for managing a deficient capsule is to extract all of nucleus, remove the cortex and the epinucleus as much as possible, do an adequate anterior vitrectomy, preserve residual capsular support, and just in case you are sure that the lens is going to be stable, go ahead and implant an IOL. The last aspect is the least of the problems. It's most important that you do not damage the eye irretrievably. And just in case a significant amount of nucleus or lens matter has dropped into the vitreous cavity, it's better to enlist the support of a posterior segment colleague. So let's look at these bunch of videos. This case I did about 25 years back. He was a physician from Ooty. As you can see over here, I had the primitive instruments. I have a large PC rent over here. You can see the anterior vitrectomy being done. Basically, the principles are remaining the same. We did not have triamcinolone acetate. I just use a Vexel sponge to make sure that there's no distortion of the rhexis margin or the pupillary margin. That tells me that the anterior vitrectomy is quite adequate. That's a 3-piece lens going into the sulcus. At that time, we did not have the concept of capsular capture that Dr. Chang talked about. So basically, I'm placing it in the sulcus there and then creating an adequate rhexis capture. It's essentially an optic capture that I'm doing. And whatever little strands of vitreous are there is again being taken care of. You can see the fairly large tear over there, but then that's the end of surgery. And this is what the patient had on the table, and this is what we ended up at the conclusion of the surgery. And mind you, this was done about 25 years back. And he continued to follow up with me. This was taken about 21 years back. The gentleman passed away a couple of years back, bless his soul. Until the end of his life, he maintained an excellent visual acuity of 6'9". We continued to be great friends. And obviously, this is just to drive home the point. Just in case you have a deficient capsule, all is not lost. As far as you use the basic principles of management of these cases, quite often you are able to retrieve excellent results. In the bag implantation with PCR, you can see all these videos are running at 2x speed. So that's the reason the bit of it's a little jumpy. A little hard cataract, basically what I'm doing is a direct chop. And all the maneuvers seem to be going quite well. My phaco probe remains steadily in the center. The nucleus fragments are flowing in. But then, as I proceed with the surgery, as was pointed out earlier, there was a surge, and I do have a PC rent, which will become a little more obvious. It's right over here, and you can see in this area. And essentially, without the chamber collapsing, I inject dispersive viscoelastic to tamponade the anterior vitreous space. Then subsequently, the vitreous has not yet presented. I inject more of HPMC on top of it. Having inflated the back quite adequately, this patient was to receive a trifocal toric intraocular lens. The lens of my choice is being injected. The Varion display is on all the time, though it's not being shown up on the video. You'll see it towards the end. So without disrupting whatever support of the capsule that is there, and with this lens going into the back, premium intraocular lens, I'm able to maneuver the haptics inside also, and then position the lens exactly according to where it needs to be, evacuate the viscoelastic quite adequately. Obviously, since dispersive viscoelastic has been injected, it takes a little time to remove that. And then, of course, inject a little bit of triamcinolone acetate to make sure there are no vitreous strands over there. Now we can see the digital overlay and the lens being exactly in the position that I want, and this significant PC rent over there. So just in case you have an adequate amount of PC support, in spite of the PC rent being there, it's possible to go ahead and implant the intraocular lens in the back with no compromise in the results. This is a basic concept all of us have to understand, in the sense that when you are doing an anterior vitrectomy, go ahead and have this cut IA mode on, where you cut the vitreous strands and subsequently aspirate. And in case when you comes to removal of the cortex material, you need not really exchange it with an aspiration cannula, but go ahead and have the IA cut, where you essentially aspirate the cortical matter, or you can just have the settings of the irrigation aspiration with the vitrectomy probe in place and then continue to function. The most important aspect is to have the highest cut rate that is possible in your particular machine that you're using. All your other parameters, the intraocular pressure, the vacuum, the aspiration flow rate, etc., has to be quite minimal and well manageable. You want the least amount of turbulence and the most controlled surgery that's possible. And what about PCR during initial chopping itself? This again is a fairly routine case, a walk in the park case. But what I noticed during my here, I have a PC rent, and what I do is to immediately tamponade the anterior vitreous phase with the dispersive viscoelastic, bring whatever nucleus fragments are there into the anterior chamber, and then with adequate covering of the endothelium, I go ahead and remove the nucleus fragments over there. You can see the fairly large rent over there, and once again I inject dispersive viscoelastic. The vitreous face is broken, but the idea is to remove as much of the nucleus fragments as possible before I go ahead and do an anterior vitrectomy. And now I go ahead and do the anterior vitrectomy where the basically irrigation cannula is separated, and through the side port the vitrectomy is done, and then subsequently removal of the whatever cortical matter is there. It's invariably in these cases there could be some lens droppings, and at the end of the a week later I would always have my vitreoretinal colleague to examine these patients to take care of it in case it's necessary surgically or follow them up closely. Then subsequently it's a 3-piece lens that's going in. Whenever you have a situation like this, it's always a good idea to place a lens in the sulcus and then create an optic capture. And as I showed you in the first case, you can get an excellent results without any compromise. So it's a fairly large lens that I had right in the beginning of the surgery, but with proper management, with proper usage of dispersive viscoelastic, moderate parameters, we are able to get the kind of results that we need. And then in case you have significant nuclear remnants still there and your anterior vitreous face is intact, I found this IOL scaffold technique, which was essentially brought up by Amar Agarwal, to be quite useful. This, you can see the one heminucleus is being removed quite completely. But before I reach out to my second bit of the heminucleus, I find that there is a fairly large rent over there. So essentially what I do is to bring the second nucleus fragment into the anterior chamber, I'm maneuvering the nucleus fragment into the anterior chamber. Then subsequently, I know that the anterior vitreous face is not broken, and I inject dispersive viscoelastic, because initially the patient was to receive a single piece intraocular lens. It was a 2.4 millimeter incision. I enlarge it to 2.8 millimeters, and behind the large nucleus fragment, I introduce a 3-piece lens and place it in the sulcus. Once you have this in place, then the propensity for the large nuclear fragment to fall back is significantly arrested, and with adequate amount of viscoelastic, I go ahead and do an anterior chamber phacoemulsification. Subsequently, go behind the lens, do an adequate anterior vitrectomy. Once again, use triamcinolone acetate to make sure that the anterior vitrectomy is quite adequate. So it's extremely important nowadays, whenever you even suspect that there is a vitreous loss, that you make sure with using this diluted triamcinolone acetate to ensure that the vitrectomy that you have done is quite adequate. And this is a vitreous wick. Here you will just keep concentrating on this particular aspect at 12 o'clock. Almost the entire surgery is going quite routinely, but once the nucleus fragment is completely evacuated, what I find is there is a slight distortion of the pupil at 12 o'clock. This immediately tells me something is wrong, because I had not really chafed the iris during my surgery. But as I was suspecting a vitreous disturbance, basically what has happened is essentially a capsular dialysis, and through that the vitreous has come out, though the posterior capsule itself is quite intact. So essentially the patient was to receive a single piece lens. So I go ahead and inject it. You can see already the vitreous popping out here. And then I inject a endocapsular ring in place. This was not, maybe it's the trauma of the surgery, because it was not a pre-existent problem. So I do not, it's not a progressive zonulopathy that we have, but I just want to give enough circumferential support. So go ahead and do an inject an endocapsular ring. Then subsequently in the subincisional area, do an adequate anterior vitrectomy. You can see the large blob of vitreous over there stained with the triamcinolone acetate. Then do an adequate anterior vitrectomy so that post-operatively the chance of any retinal issues are taken care of. There's no inflammation, and you have the lens well settled in the bag and a good outcome. And you can have problems. This was a gynecologist friend of mine. One I already operated with a premium intraocular lens a week back. fairly routine surgery, fairly dense cataract, and you can see that the first time I suspected something wrong was when I found that there was something floating in the anterior vitreous. And then you can see a small, at this 6 o'clock position, there is a small discontinuity, and this is the area of the PCR, but adequate amount of posterior capsular support was available. And since the lady had already received a trifocal lens in the other eye, a continuous range of vision lens in the other eye, I go ahead and decide. And here I'm enlarging the incision so that I do not do a wound-assisted implantation. And I'm essentially directing the lens in the area where there's adequate capsular support. And in spite of this fairly large area of capsular defect, I'm able to implant a premium intraocular lens within the bag and get optimal results. So friends, the point I want to drive home is that posterior capsular rent is obviously a complication all of us do not want to avoid at any cost. But just in case you have it, you are always able to manage it. I just did not show anything happening in the posterior segment, because if there is a intraocular lens drop, if there's a significant lens material dropping in the vitreous cavity, then I think it goes beyond the realms of our capabilities, and it has a posterior segment surgeon help has to be enlisted. Thank you so much for your kind attention.
Thank you very much, Dr. Ram. Excellent presentation. I think all of us